Okay, we'll talk in this second part about the oral infections. Firstly, you should know that there is what's called the aorta septum, which is connect the periorta to the tarsal plate. So any infections or inflammation in front of the tarsal of the septum is called pre-septal cellulitis, and what's behind is called orbital cellulitis. It is very important to differentiate between these two terms because the management will be different. Source of orbital infection could be extension from nearby structure as nose or lacrimal gland, or it may be dental origin. Also it could be exogenous by trauma, or endogenous through sepsemia or bacteremia. First, we will discuss pre-septal cellulitis, which is less dangerous, and it means that the inflammation here is in front of the orbital septum. The clinical picture, as you see here, there is swelling of eyelids, and there is erythema, redness, and also we may see the origin of pre-septal as a scar or site of injury, as you see in this picture. It could be extension from nearby structure. This is another case showing orbital cellulitis. In orbital cellulitis, the very important to note that the ocular motility will be affected. So there is ophthalmoplegia in addition to signs of inflammation in the eyelids and proptosis. Manifestations of orbital cellulitis is unilateral erythema, edema, warmth, tenderness of eyelids, fever, systemic illness also could be seen as general manifestations, and it's very important to differentiate between orbital cellulitis and pre-septal cellulitis by the following: visual changes, ophthalmoplegia, proptosis, chemosis, limited ocular movement, and abnormal light reflexes. Orbital cellulitis could be seen in young age, in children, or in old age. Usually in young age it is due to ethmoiditis, which is extension of the infection from the ethmoidal sinuses through a very thin bone, which is lamina papyracea. But in old age you can suspect sepsemia, bacteremia, or exogenous injuries, which could lead to this orbital cellulitis. Concerning the clinical picture of orbital cellulitis, as we said before, it could be general fever, headache, rigor, malaise, ocular limited movement, which is very important with proptosis, CNS, which in form of coma or convulsions, and nasal manifestations could be in form of sinusitis. The complications of orbital cellulitis could be sepsemia as a general complication, or ocular complication, which is corneal because of proptosis, lead to corneal ulceration and panophthalmitis. Also CNS cavernous sinus thrombosis, and meningitis. Clinical picture of aortic cellulitis will be varied according to where the abscess is formed. Is it aortal abscess, or it is diffuse cellulitis, or supraosteal abscess, or it may be complicated and become cavernous sinus thrombosis complication. How to differentiate between preceptor cellulitis and aortal cellulitis? In preceptor cellulitis, there is painful swollen eyelid extending beyond the aortal rim. Normal vision and ocular motility is normal, while the conjunctiva is white and no proptosis, maybe mild fever or no fever. But in aortal cellulitis, there must be decreased of vision, restricted ocular motilities, and also proptosis. Fever and malaise is a common symptom. Also, it is very important to differentiate between aortal cellulitis and when it becomes complicated with cavernous sinus thrombosis. The most important one is the bilaterality. If the condition in aortal cellulitis is usually unilateral, but it becomes bilateral, so you must suspect that there is cavernous sinus thrombosis. Also, the first muscle will be affected on the other side is lateral rectus, because affection of abducent nerve, which is the sixth cranial nerve. Complications of aortal cellulitis are very dangerous, as it is usually intracranial: meningitis, cavernous sinus thrombosis, aortal abscess, and vision loss. The most important concerning the treatment of aortal cellulitis is the admission, which I mean by admission is hospitalization. The patient should be admitted to the hospital and receive gram-positive and antibiotics in the form of broad-spectrum antibiotics covering both gram-negative and gram-positive and anaerobic infections. Follow up for vital signs. If we feel that the condition is worsened, we must interfere by drainage of the abscess. Also, specific treatment could be given if we suspect fungal origin of infection, or if the case turned into cavernous sinus thrombosis, by giving something to dilute and destroy the thrombus and return the blood again normal.